So there's a big unanswered question here that is the elephant in the room. Let's say we use the DB11 approach. Our patients hopefully are getting pathologic complete response, but some of them won't, right? What do we do for a patient who had DB11, has been exposed to T-DXd, and then has residual disease at the time of surgery? Acknowledging we don't have data on this. But can we help our colleagues out?
I think it's a challenge, right? And so now you're exposing the patient to 14 cycles, right, of T-DXd.
So you would start with T-DXd in the neoadjuvant, and then you'd revisit it in the adjuvant setting.
And as Dr. Gradishar said, he said, oncologists are what? Very creative, right? And so I think you kind of take the data and try to be additive in that situation. But knowing that, I think that's one of the challenges. What we don't know is the ultimate ILD toxicity to these patients. How much vigilance are you going to have in terms of monitoring these patients? And then the other side effects, right? The GI side effects, along with the cytopenias and peripheral neuropathy that we did see in DB05. How much will that be impacted by how we change the regimen in terms of going from neoadjuvant to the adjuvant setting?
Okay. So you wouldn't rule out that there still may be more activity of T-DXd that we can squeeze out for these patients?
We just don't know at the moment.
And again, it's an extrapolation, but the data that Park presented about the depth of the PRs, and if you had a deeper PR, so suggesting that if you continued therapy, maybe you're conferring a benefit.
Yeah.
So it's an extrapolation to put it in this setting, but it's sort of the same message. If the patient was tolerating T-DXd up front, still had residual disease, I would also think about continuing, because maybe you could deepen the effect of the drug with longer therapy.
So that's the data that we saw at this meeting, where for metastatic patients, the depth of response actually may have taken a little longer for most patients to reach their maximal response.
Right.
80% by 2 years in the metastatic setting, which I don't know that any of us would have actually picked that particular number. At least I wouldn't have. It's a little longer than I expected. And I think some of us were swayed in the third arm, in DB11, where the patients had T-DXd for 8 cycles, and that arm didn't seem to perform as well, and so was shut down. And what we have seen is T-DXd for 4, followed by THP, as you said, versus the standard. But I think that metastatic data actually is reassuring, that maybe the answer is longer duration, and it was more than those 8 cycles that we originally saw. So, because at the end of the day, we're just guessing with any of these durations, right?
Absolutely.
So.